that case. So I acknowledge that the screen has gone off for a bit. Let's just be patient and the screen is going to come on again. Like I said, it's a pattern reel. And so things are going to be very real. So please make sure you use the chat box to introduce yourself. We want to know who is on the call and what are what's your take on the session. Introduce yourself. If you have questions, please feel free to also put them on the chat box. And right now I'm going to hand over to Dr. Kevin to take us through the first case. Thank you and over.
Thank you very much, Dr. Vanessa, for giving me the floor. I hope I'm audible enough.
Yeah, sure. You can go ahead.
Okay, thank you. Okay, so I'm going to present to you the case of a child that we have in our hospital. I'll proceed in French. Donc, c'est un patient de 10 ans de sexe masculin qui a 23 kilos, qui vit présentement avec sa grand-mère et ils sont des témoins de Jéhovah. Malheureusement, il est orphelin de père et sa mère est également sur traitement et au moment de cette consultation, elle vivait à Douala et n'avait pas de profession. L'enfant vit dans des conditions très pauvres avec une nutrition assez inadéquate et il vient généralement pour ses rendez-vous et il vient aussi pour les charges virales sans manquer. Donc, le patient s'est présenté à cette consultation avec des légères lésions cutanées en dessous des narines à type d'impétigo depuis à peu près une semaine, selon son garde malade. Donc, il est sur traitement antiviral depuis octobre 2021 et voici les différentes molécules qu'il a prises. Et présentement, il est sous Abacavir et dolutegravir 50 mg. Donc, il prend ça depuis décembre 2023 jusqu'à ce jour. Diapo. Voilà. Donc, voici un peu l'évolution des charges virales de notre enfant. Il avait des charges virales assez élevées. Quand on a constaté ça, on a essayé de faire un renforcement thérapeutique. Depuis 2021, on a fait un renforcement thérapeutique et en 2023, en novembre 2023, on a eu une baisse de sa charge virale qui est descendue jusqu'à 146. Mais après ça, les résultats de novembre encore sont revenus très élevé, même plus que les autres fois. Et on s'est rendu compte que c'était à cause d'une mauvaise adhérence au traitement, de par le fait que les adultes avec lesquels il vit ne sont pas assez attentifs. Donc, il sautait beaucoup de jours de traitement. Voilà. Donc, ce qu'on a décidé de faire, on a d'abord fait un counseling à l'enfant avec une éducation et un langage adapté à son âge. Ensuite, on a traité l'impétigo qu'il avait. On lui a prescrit de l'amoxicilline et puis on a prescrit aussi des soins locaux pour les lésions. Ensuite, on a constaté que le poids de l'enfant stagnait autour de 23 kilos depuis 2023. Donc, on a essayé de faire un counseling à l'enfant lui-même, vu que ce jour-là, il était venu seul. On lui a fait un counseling sur la nourriture, mais étant donné qu'on savait que ce ne serait pas suffisant, on a demandé à sa mère de venir. Et puis sa mère est venue et là, on a essayé encore de faire un counseling plus approfondi. Et on a fait comprendre à la mère l'importance du fait que le fait qu'il vit uniquement avec sa grand-mère, elle ne peut pas le suivre comme une autre personne ou bien comme elle-même la mère. Donc, quand sa mère est venue, on a refait l'aide à l'observance à sa mère pour qu'elle le suive mieux. Et on lui a aussi dit que l'idéal serait qu'elle vive avec l'enfant. Et c'est à elle qu'on a plus fait le counseling nutritionnel. Voilà ce qu'on a fait comme intervention. Donc, euh, on n'a pas eu un challenge particulier parce que présentement, on va faire le contrôle de charge virale dans 3 mois pour cet enfant. Mais nous, on avait des questions pour les experts sur ce cas-ci. On aimerait savoir quelle est la meilleure approche pour un adolescent, pour la prise en charge d'un enfant ou un adolescent qui vit avec le VIH, surtout un enfant comme celui-ci qui ne prend pas le poids. Est-ce qu'il y a des enseignements clés qu'on devrait rentrer avec? Et pour nous, ce qu'on a appris du cas de ce jeune homme, c'est que le suivi efficace d'un enfant ou d'un adolescent dépend de l'intérêt que l'adulte porte à ce traitement. Si l'adulte ne suit pas le traitement, l'enfant va négliger. Voilà. Or, depuis que sa mère est venue, elle a même décidé de vivre avec l'enfant dorénavant dans cette ville-ci, à Baham. Donc voilà ce que nous on a appris et ce qu'on a pour les experts, c'est comment est-ce qu'on peut mieux prendre en charge un adolescent sur le plan nutritionnel. Merci beaucoup.
OK. Merci, docteur Kevin, et merci pour votre présentation. Et félicitations à vous et à toute de l'équipe de l'hôpital de district de Baham. Um, if you are just joining us, you're welcome to this session of Patario that is, it is crafted for Cameroon by Cameroonians. So please, I just want to see that our theme for today is management of children with high viral load. And so please, if you're in need of translation, go to the more icon at the bottom of your screen and you click there, you'll see a globe and you click on the globe, you'll be able to have the translation in the language you're comfortable in. With that said, I'll open the floor now to our experts. We have Dr. Atanga, we have Dr. Alice, we have Dr. Sandrine for their inputs and also to help respond to the question that District Hospital Baham have raised. Thank you.
Hello.
Yes, Dr. Sandrine, you have the floor.
Thank you so much, Dr. Vanessa, et merci à Dr. Kelvin pour la présentation et pour le partage de ce cas. Donc, je vais apporter des éléments de réponse et les autres experts, en l'occurrence Dr. Atanga et Dr. Alice, vont ajouter à ce que je vais dire. La première des choses, c'est que l'enfant, la prise en charge de l'enfant, ça implique plusieurs choses. Le souci ici, c'est pas seulement un souci nutritionnel. Je vous ai entendu dire que vous n'avez pas vraiment un challenge pour ce cas, mais vous avez un gros challenge. Et le gros challenge, c'est que vous avez un enfant de 10 ans qui a des charges virales élevées à répétition. C'est-à-dire, sur les 4 charges virales qu'il a faites, je crois 4 ou 5, il y a une seule qui est une charge virale supprimée. Et tout ne se résume pas à la prise en charge nutritionnelle. Il y a beaucoup de choses qui entrent en jeu. Bien sûr, la prise en charge clinique, la prise en charge psychosociale et la prise en charge de suivi même nutritionnel de l'enfant, comme vous avez si bien évoqué. Maintenant, la nutrition de l'enfant affecte sa charge virale, pas directement, mais bien sûr, ça a des effets sur la charge virale de l'enfant et bien sûr sur le bien-être. Quand je dis pas directement, ça veut dire quoi? On ne va pas dire que si quelqu'un n'est pas bien nourri, la charge virale est basse. Mais on sait que si un enfant n'est pas bien nourri, ou bien si quelqu'un qui vit avec le VIH n'est pas bien nourri, soucis à même prendre les médicaments. Et certains médicaments sont mieux absorbés quand le patient a mangé et a mangé pas seulement n'importe quel genre de nourriture, mais on sait également que les nouvelles molécules sont des molécules qui sont plus patient-friendly, comme on dit. Ça veut dire que c'est plus facile aux patients à prendre en termes du nombre de comprimés, en termes même d'absorption du médicament par le patient. Donc, je veux dire que déjà au Cameroun et surtout à l'Ouest, nous sommes assez bénis avec plusieurs types de nourriture, de denrées que nous avons. Nous avons presque tout et c'est vraiment à vil prix. Donc, ce qu'il faut faire, c'est déjà d'utiliser ce que nous avons comme des denrées qui sont disponibles à notre disposition pour expliquer au tuteur de l'enfant comment, avec des choses simples, améliorer la nutrition de l'enfant en s'assurant que cette nutrition soit équilibrée. Quand il s'agit, c'est-à-dire quand je dis équilibré, c'est comme nous savons, il faut qu'il y ait les protéines, il faut qu'il y ait également les féculents et tout ce que ça comporte, les fruits. Et nous avons assez de fruits et de légumes. À l'ouest Cameroun, nous avons pour les protéines, nous avons le haricot, nous avons les poules du village qui nous pondent les œufs qu'on a facilement dans les ménages à l'ouest du Cameroun. Et nous avons ce que nous appelons le poisson sec, qui est aussi pas très cher, mais quelque chose qui va apporter assez de protéines à l'enfant si c'est bien utilisé. Et c'est pour ça que je dis que notre problème peut ne pas être un problème qui se limite à la nutrition, mais on doit voir l'enfant dans son tout. Est-ce que chaque fois que cet enfant a eu les charges virales, vous avez fait suffisamment le renforcement de l'aide à l'observance en utilisant les fiches, parce qu'il y a des fiches appropriées et ces fiches nous aident à identifier les barrières. Est-ce que vous avez identifié les barrières? Pourquoi est-ce que l'enfant n'arrive pas à prendre le médicament? Je sais que vous avez dit que les adultes qui vivent avec l'enfant ne sont pas trop peut-être impliqués, mais pourquoi est-ce que l'enfant ne prend pas le médicament? Qui est vraiment responsable? S'il y a plusieurs personnes, il serait important d'identifier le responsable principal, de travailler avec cette personne-là. Et si cette personne-là n'a pas assez de temps pour prendre soin de l'enfant, qui est une autre personne qui va vraiment prendre en charge le suivi de l'enfant. Pourquoi l'enfant n'est pas avec sa mère? Bon, sa mère n'a pas de travail, peut-être c'est pour ça qu'elle a laissé l'enfant chez sa grand-mère. Mais il faut déjà, chacun a sa partie à jouer là. Le personnel de la santé doit s'assurer que le suivi d'un enfant avec charge virale élevée soit fait de manière appropriée en utilisant les outils. Et là, j'ai mentionné le formulaire de renforcement d'aide à l'observance. Bien sûr, insister aussi sur la partie nutritionnelle, mais en montrant au tuteur de l'enfant, dans ce cas la grand-mère, les choses simples qui sont disponibles, même chez elle dans la cour, qui peuvent aider cet enfant à rapidement être remonté en matière de nutrition et finalement aussi la prise en charge clinique, bien sûr. Quand on regarde vos charges virales, je n'ai pas l'impression que c'est fait tel que ça doit être fait. C'est-à-dire que 3 mois après une charge virale élevée, avec bon renforcement d'aide à l'observation, on doit faire une autre charge virale qui n'est pas le cas. Donc, je vais m'arrêter là pour donner la place aux autres. Merci.
Ok,
Merci, Dr. Sandrine. Oui, Dr. Alice, you have the floor.
Okay,
Thank you.
okay. Thank you very much, Kevin, for that wonderful presentation on this case study. Je voulais déjà vous féliciter pour le travail que vous faites au bénéfice des enfants et des adolescents vivant avec le VIH. Donc, à la suite des questions posées par le docteur Tala, je vais beaucoup m'appesantir sur le volet éducation thérapeutique, tout en posant les questions de savoir, est-ce que dans votre hôpital, est-ce que vous avez un groupe de parole? Est-ce qu'il y a un groupe de parole pour les enfants? Est-ce que à l'hôpital, vous avez des adolescents champions? L'adolescent champion, c'est qui? C'est-à-dire un enfant ou un adolescent qui a transcendé toutes ces étapes, c'est-à-dire que qui est passé peut-être du protocole A au protocole B et qui finalement, après tout ça, a une charge virale indétectable. Bref, un patient qui n'a pas d'infection opportuniste. Est-ce que ce genre d'enfant existe dans la formation sanitaire? Parce que le plus compliqué, comme a dit docteur Tala, qui offre les soins et les services à cet enfant? Parce que de nos jours, il est difficile pour un adulte, ça il faut le dire, c'est-à-dire qu'il est difficile pour un adulte d'offrir des soins, comment est-ce qu'on va dire, différenciés, adaptés, c'est la terminologie que je cherchais, à ces enfants ou encore à ces adolescents. Qui offre ce soin? Et est-ce que vous avez cherché à regarder s'il y a une sorte de complicité entre la personne qui offre le soin et l'enfant? Parce que parfois, quand ça ne va pas, nous conseillons même de changer peut-être l'accompagnateur psychosocial. Est-ce que vous en avez? Est-ce qu'ils ont reçu des formations? Ça, ce sont des questions auxquelles vous devez vous poser. Qu'avez-vous fait depuis que cet enfant présente des charges virales indétectables à votre niveau? Vous avez investigué et vous avez identifié quel est le principal facteur qui est associé à cette faible observance au traitement. Donc, vous voyez qu'on a besoin des autres informations pour pouvoir vraiment vous orienter. Mais pour ne pas être long, je pense que il va falloir renforcer l'éducation thérapeutique. C'est-à-dire que vous devez continuer à montrer quelle est l'impétence de prendre ce médicament à cet enfant et surtout quelles sont les conséquences qu'il court si demain ils ne respectent pas ça. Et surtout avec les enfants. Lorsqu'on fait l'éducation thérapeutique, nous devons insister sur le projet. C'est-à-dire toujours demander à l'enfant, quel est ton projet? Nous savons que le VIH, c'est une maladie chronique. C'est-à-dire que pour le moment, en attendant que la science évolue, c'est-à-dire qu'il faut toujours demander à l'enfant, quel est ton projet? Il va te dire que je voudrais être comme docteur Kitty a dit demain. Je voudrais être comme Tata Vanessa. Je voudrais être comme Samuel Eto'o, le président de la République. Et à chaque fois qu'il trébuche, vous allez utiliser ça comme source de motivation. Alors là, si tu veux vraiment être comme Samuel Eto'o, je pense qu'il faut que tu prennes. Donc, il y a ces stratégies qu'il faut utiliser pour amener les enfants parce que ce n'est pas évident. Donc, à la suite de ce qu'a dit le docteur sur le plan nutritionnel, je voudrais quand même poser ces questions et insister sur le fait que l'éducation thérapeutique doit être faite sur cet enfant pour essayer de voir qu'est-ce qui peut facilement nous aider à sortir cet enfant de cette virémie élevée. Je vais passer la parole au docteur. Peut-être qu'il vous a dit quelque chose. Merci.
Yeah, thank you very much, Dr. Kecheji. And I want to really thank the team from the Benham Hospital for the management of that child. I just want to highlight a few things here. I know, the management of children, especially adolescents, is quite challenging. But again, one of the things that you must note is that in the management of children, if it's possible to identify who is directly responsible for the child, that will be very, very key. In this case, you had the grandmother. I don't know if in addition to the grandmother, there were other elders at home who were also taking part in the child's care. But it's usually better if you have 3-4 persons who live with the child. We identify who is responsible, and that person should be able to give us clear information as to whether the child is taking his or her treatment properly. Because when it becomes everybody's job, it becomes very, very difficult to know whether the child is being properly followed up or not. So again, it will be very, very important. I'm happy you say the mother has come back. Let's consider that she's the principal person who should follow up the child, and then you work with her to make sure that that is well followed up. I mean, in your plan, I saw. I mean, you did well looking at all the various issues. I just also wanted to check. This is an adolescent, 10 years and getting older. Normally, for children, you need to screen them for all different opportunistic infections. I know that is what must be classically done. You needed to screen for TB and make sure that you really screen for TB, both pulmonary and extrapulmonary, because we've actually had children who might be doing well with adherence, but at times they just have an occult infection. And once that is not well identified and treated, you might not be able to really make any good gains, especially in terms of weight gain. That again, you need to look at that. I see for the child's treatment, you went through quite a good number of protocols. I think that if you are already on a DTG containing regimen, that is the most optimal protocol. And I think that protocol should be able to get this child suppressed if adherence is good, because from the way this case is presented, the major issue there is adherence. And if you actually help the child to have a good nutrition and optimize the treatment and make sure the adherence is good, I think we are going to get better results. So I think I just want to emphasize on the need of having somebody specific who is responsible for the child's treatment and not just everybody. And just as Dr. Keteji actually highlighted, for children, you really need to help them identify and understand, the importance of being on their treatment. I mean, their treatment goals, and you have to help them identify those goals themselves, and then you also share. So the other thing that I don't know whether you're able to have is that in a treatment center like that, if you have support groups for children, it will also be important to do what we call, to also have a support group for parents. That's in other contexts, we talk about parents' guidance forums, because just as you provide education to the children in support groups, that's helping the peers to help other children improve on their treatment, is the same type of feeling that you have when you bring the parents of so many children together. Because in that forum now, what happens is that the parents start learning from each other the importance and the successes that some parents are making that they might not be making, and that might be an opportunity for them to reach out to those other parents who have children who are so successful on treatment, and then they will learn from those children, from those parents. So if you also eventually develop a parent guidance forum in your hospital, that is also going to be a plus, because parents will also start learning from the experience of parents who have children who have done very well on ARVs. And in that way, they'll be able to understand that it is possible to bring up those children, and so they will put more effort in taking care of their children, because they have seen parents who have done excellently well and their children are doing very, very well. So that will be an opportunity to do some sort of peer learning amongst the parents and the guardians. So that could also be another thing that you want to add. I just want to end there. I know we'll have opportunity to discuss more cases. Thank you and over.
Thank you very much, and thanks to all our experts. And if you are just joining us, you are onto Cameroon Pataril that is prepared by Cameroonians for Cameroonians. And the focus for today is on managing children with high viral load. And we have just come to the end of the first case, which it was clear that the main issue was an issue of adherence. And we've had our experts give their inputs, and I'm hoping the Baham district team has taken note, and they are going to employ all of these to make sure that our child has a better outcome. Please use the chat box to introduce yourself and ask your questions. There is translation available. You go to the More tab at the bottom of your screen and you click on interpretation. There you can switch to the language in which you're more comfortable, whether French or English. So again, thank you for joining us, and we're going to be moving on to the second case, which will be presented to us by Madame Judith Jolefak, who is the coordinator of the District Hospital Bamenju. Madame Judith, si vous nous attendez, pardon, ouvrez votre micro et faites votre présentation. Merci. Allô, Madame Judith?
Allô, Doc.
Oui.
Bonsoir.
Pardon, faites votre présentation.
Ok, Doc. Bonsoir à tous et bon après-midi. Nous allons présenter le cas de notre adolescent de Bamenju pour la prise en charge de l'adolescent vivant avec le VIH dans un contexte socio-économique complexe. Premièrement, nous allons commencer par les antécédents de notre ado et les circonstances familiales. Notre ado est âgé de 19 ans, de sexe masculin, pesant 54 kg, et il fait la classe de 4e année maçonnerie. Il est un orphelin de père et de mère, vivant avec son arrière-grand-mère qui fait les champs pour se nourrir. Et sa seule sœur est séronégatif, et il est seul qui vit avec le VIH dans la famille. La grand-mère, qui est infirmière retraitée de l'hôpital district de Bamenju, n'a pas accepté d'être la tutrice directe de son petit-fils, malgré plusieurs essais de la convaincre à le faire par le personnel de l'hôpital. Et en deuxième position, nous avons la présentation clinique. Présentement, l'enfant a les démangeaisons généralisées sur tout le corps. Et il a fait le zona abdominal récemment et il y a environ 3 mois, tel que rapporté par la grand-mère, qui dit lui avoir donné de la cyclovie qui l'a soulagé. Et il se sent mieux malgré les douleurs neuropathiques. En troisième position, nous avons le diagnostic historique du traitement. L'enfant a été diagnostiqué pendant une hospitalisation et mis sous traitement en octobre 2014 à l'hôpital régional de Bafoussam. et il était transféré de l'hôpital du district de Bamingui. Et son protocole d'initiation est inconnu. Concernant le changement de protocole, en 2017, l'enfant était sur Zidolam et Favirenz. Et en 2018, il était sous Zidolam Nevirapine. Et de nos jours, il est sous TLD. Et tous ces changements étaient pour le but de faire l'optimisation. Et en quatrième position, nous avons l'historique de la charge virale. Ces tendances de charge virale au fil du temps. En 2023, sa charge virale était indétectable et il était sur Isolam Nivirapine. Nous avons observé là une bonne observance. Et en 2020, l'enfant était sur TLD. Et l'enfant est sur TLD jusqu'à nos jours. Et les deux autres charges virales qu'on a pu faire, c'était tellement élevé. À cause de tout cela, à cause du non-respect des rendez-vous, après plusieurs séances de TP faites. Et en cinquième position, nous avons les interventions médicales et plans d'action. Les interventions médicales effectuées jusqu'à présent, y compris les traitements, les procédures ou les changements de gestion, tout soutien et toute orientation fournie, y compris les conseils, les services sociaux et autres orientations aux patients et à sa famille. Plusieurs séances de renforcement d'aide à l'observance faites à l'enfant et à sa famille. Plusieurs visites à domicile faites pour comprendre l'environnement socio-culturel dans lequel l'enfant vit afin de mieux renforcer l'aide à l'observance. La tentative de mettre l'enfant en contact avec un ado champion qui réside Baham a échoué. Et en sixième position, nous avons quelques défis et questions pour les experts. Comme question, comment offrir la meilleure qualité des soins dans un contexte socio-économique complexe? Et comme défi à relever, l'adolescent était abandonné à lui-même sans soutien familial ou social pour sa prise en charge. Et plusieurs charges virales élevées consécutives malgré les séances de renforcement d'aide à l'observance dues à la mauvaise observance. L'enfant est rejeté à un rejet familial par sa grand-mère. Je vous remercie pour votre aimable attention. Oui. Ce que je n'arrive pas. Oui, peut-être docteur Sandrine.
Please go ahead to the experts. Dr. Sandeep, do you want to please go ahead with your response? We're waiting for Dr. Vanessa to join us. She's having some trouble, but please go ahead.
OK. Merci à Judith et à toute l'équipe de Bamenju pour avoir présenté le cas de cet enfant et pour tous les efforts que vous avez déjà consentis pour aider dans la prise en charge de cet enfant qui n'est pas facile parce que on se retrouve dans une situation où qui est un peu comme le cas qui vient d'être présenté par Baham. C'est un enfant qui n'a pas le soutien de sa famille tel qu'il faut l'avoir et du coup, ça devient un peu compliqué puisque la grand-mère qui, elle comprend mieux puisque étant de la santé, ne veut pas vivre avec l'enfant. Il se retrouve chez son arrière-grand-mère, sa maman étant décédée. Comment offrir la meilleure qualité de soins dans un contexte socio-économique complexe? Ce n'est pas facile, mais je vais commencer par dire que, comme on l'a relevé dans le cas qui vient de passer, c'est important de trouver des stratégies pour vraiment renforcer la prise en charge psychosociale en utilisant, comme Dr. Ketchaji l'a soulevé, les rêves de cet enfant. C'est-à-dire, qu'est-ce qu'il veut devenir dans la vie et comment est-ce qu'il peut le devenir. Si on discute avec lui, vous pouvez même être surpris de comprendre que c'est un enfant qui n'a même pas de rêve. C'est-à-dire qu'il peut même être un enfant qui a des troubles mentaux, puisque quand tu regardes son âge et sa classe, tu te rends compte que son développement, même psychosocial, ne suit pas celui de tous les autres. Donc, c'est un peu compliqué, mais je pense qu'il faut commencer par d'abord travailler avec l'enfant de plus en plus en l'aidant, lui donnant l'amour de vivre, la volonté de vouloir vivre. Et s'il a la volonté de vivre, il doit pouvoir prendre sa prise en charge en main, s'assurer que il a l'annonce totale, qu'il comprend exactement euh, pourquoi il doit prendre son médicament, comment est-ce qu'il peut devenir comme ce qu'il voudrait vraiment devenir demain, donc s'assurer qu'il ait l'annonce complète. Il faut continuer à travailler avec la grand-mère parce que on ne sait pas encore pourquoi elle refuse de prendre son petit-fils pour vivre avec lui ayant perdu la maman de cet enfant qui est sa fille. Est-ce qu'elle a il peut y avoir des choses qu'elle n'a pas partagées avec vous, donc il faut qu'on continue à travailler avec elle qui, étant du corps médical, comprend mieux les enjeux de cette prise en charge, mais il faut comprendre quelles sont ses craintes et l'accompagner à surmonter ces craintes-là pour aider son petit-fils qui a des soucis. Et essayer encore, comme on l'a aussi dit, je sais qu'avec le nombre d'enfants que vous avez, vous pouvez ne pas avoir des groupes de soutien, mais essayez encore la possibilité de le mettre en contact avec les pairs pour un soutien de pair. J'ai vu ce genre de soutien marcher comme de la magie, c'est-à-dire quand une autre personne qui a son âge peut se rapprocher de lui et lui parler en utilisant son histoire, ça peut vraiment l'aider, le revitaliser et lui donner encore la force de continuer. Donc, je vais m'arrêter là pour donner la place aux autres. Merci et au revoir.
Merci. Thank you. I think I'll hand the floor to Dr. Atanga. But if you are just joining us, please feel free to introduce yourself in the chat. If you have questions, put them in the chat. And also, there is interpretation available. Just go to more, and then you see the icon that looks like a globe, and you click on it, and you can have access to interpretation. Again, we are talking about managing high viral loads in children and adolescents living with HIV. Dr. Tanga, you have the floor. Thank you.
Yeah, thank you very much, Vanessa. I want to once more thank the Bamenju team and Judith for the presentation. I think we have here an adolescent, 19 years old. I think somebody who is, at a certain age that I'm sure disclosure must have been complete. He already should know exactly why he is on treatment and the purpose of the treatment. And I think the major problem that the facility raised here was having an orphan who is not getting enough family support. Again, one of the things that we need to highlight here is the need to really more into the family to really understand the family dynamics. Just as Dr. Sanju was saying, it's always very, very important to find to look into the family more deeply with the child, look into the extended family, and see if there is somebody who is ready to really take up the responsibility of supporting this child. At times, the problem is you might have the grandmother who is not cooperative, and they might not be ready to open up to other family members. That's usually happens a lot. So, the child at that age, I think you can really they can talk with the child to really understand who are other family members that they can open up to. So, looking at the family dynamics very well and tracing the family tree, we could along the line find somebody who could be helpful to supporting this child. This child goes to school and somebody is paying the fee. It means somebody has an interest. So I think that disclosure here for the and again, looking at an important person in the family that can be disclosed to and who can helpful of this child could be helpful. For us, it might be very, very challenging if this child is left alone. We have talked about the peer education, which is very important. And I know you tried already to put the child in contact with other peers, which was difficult, but I think that process should continue until you see if you can really find a peer who can really be talking to this young adolescent. The other thing that I wanted to add here is that looking at his viral load, we are very, very certain that adherence is a problem. You see, the child is on TLD, a very potent regimen, and the viral load remains very, very high. In virology, this is instead a good sign for us in the sense that if the viral load is very high, it means that the virus is still very naive and the virus is multiplying very fast, which therefore means that if this child were to take his treatment well, this child is obviously going to suppress. So I think the size of the viral load that we are seeing here on these two last viral loads with the child on TLD is a clear indication that this child doesn't take the treatment. And so we have a very big opportunity to get this child, take this treatment well, and then get him suppressed. Because if we were already lingering with viral loads less than 5,000, that's where I will have a concern. But here we have viral loads that are hundreds of thousands. So I think that is the opportunity that we have with this case. So if we able to really identify a key actor in the family who can support this child and then also counsel the child and get the child to be talked to by another peer, and I think that we were able to get this child swallowed his pills and get suppressed. So it is not a case that we should give up on. It's it's a very promising case. Please, let's just see what we can do. And I think we are going to get viral suppression. This is a clear case of non-adherence. It's not a problem. It's not a problem of resistance. Thank you, Anova.
Thank you very much, Dr. Atanga. Merci à l'hôpital de district de Bamenju. J'espère que vous avez reçu les mesures en emploi pour assurer que l'enfant là doit être une charge virale supprimée. Donc, merci encore. Si vous nous rejoignez maintenant, pardon, il y a l'interprétation ici en bas. Regardez en bas de votre écran et vous voyez une chose que ça ressemble comme un monde, comme ça. Pardon. Utilisez ça pour avoir le traduction. Et mon français est fini. This is very real, eh? We are keeping it real. So if you are just joining us, again, we are talking about management of high viral load for children and adolescents living with HIV. And you can use the chat to put in your questions and introduce yourself. And also, we'd just like to know how it's going. I'm hoping that everybody is hearing or is able to get us. So please feel free to indicate in the chat if you have any challenge, so we know how to come in and assist you. Right away, we are going to be moving to the third case. And again, because we say things are very real, our third presenter was having a lot of challenges with network. So I don't know if Mr. Dixon is connected now. If not, I will call on Dr. Ambe, who is the coordinator of that center, to step in and help us with that presentation. Dr. Ambe, if you can hear us, you have the floor. Thank you.
All right, good afternoon to everybody. Sorry, having some
Good afternoon, you can go ahead.
Some challenges with network, but we are going to try our best. So the third case we are going to be presenting on comes from the Ngwa District Hospital in the Northwest region. And I'll be presenting Dr. Ambeju. Slide, please. So this is the case of a 17-year-old female living with a grandmother who knows her granddaughter's status. The grandmother is not positive. The mother is also on treatment, but in another site, so it's not with us. And the whereabouts of the father is unknown. She dropped out of school in primary level due to financial constraints, and she's presently unemployed and just sits at home and sometimes goes into the farm. The economic background of the family is poor. The economic background of the family is poor, with the family barely feeding on most days. The hygienic conditions are equally not the best. She has been stubborn from when she stopped going to school, mostly running away from home to be with friends, periods during which she does not take treatment. She was fully disclosed to 2 years ago when she was 15 years old. So in July 2003, she stopped taking treatment and was out of treatment for 4 months. And around November same year, she was found abandoned in one house, and she was brought to the hospital with complaints of watery stool, severe weight loss, vaginal discharge, and rashes on the skin. And then on close examination, she was pale with a weight of 36 kilograms. So there was a decreased skin sugar, and then there was hypogastric tenderness. So there was a pus fluid discharging from the rashes on the skin, and she was diagnosed with wasting syndrome, pelvic inflammatory disease, and bacterial dermatitis complicated by anemia. She was then rehydrated and then treated with antibiotics, and she recovered. A test for tuberculosis could not be done at the time because she was subsequently given the sputum container, which she did not return to the facility till date. She was diagnosed, the diagnosis and the treatment history. She was diagnosed in 2011 in the Ngwa District Hospital, but was referred to start treatment in another facility and then transferred back to the Ngwa District Hospital in 2016. She lost one sibling, cause of death is unknown, and the other 3 living siblings are negative. History of the father is unknown. So her regimen from 2026 to 2022, she was on the following treatment: lamivudine, tenofovir, and nevirapine. And on the 5th of May 2022, she was then optimized. And then from 2022 to 2024, she started taking daily right up to the 29th of February 2024, where her treatment was then optimized to TLD based on her weight. Her viral load history. We see that her viral load has been high right from 2017, where she was on tenofovir, lamivudine, and nevirapine. That's 3,000, and progressively has increased right up to the last one that was done on the 31st of January 2024, while she was on TLG. She had a viral load of 196,110. But we realized that in 2003, she had a viral load of less than 40. So we see that that was during the period where she abandoned treatment, and it had to go up again to 196,000. Slide. So the medical intervention and the course of action. We have done frequent home visits to ensure adolescent is taking drugs as prescribed, financial support to get some drugs and some foodstuffs for the adolescents have been done. So the key challenges and the questions for our experts. What is the key clinical challenge faced in managing this case? When she presented with multiple infections. So these are the key challenges that we face. When she presented with multiple infections, there was some confusions as to what to manage first. So that's our challenge. What do we manage first when we have multiple clinical presentations of infections in this our case? We did not have the platform to do all the tests she needed. Our platform is not the best. We cannot do some other tests like the gene expert if she will not produce sputum and some other maybe full blood count and some biochemistry lab tests will not be done because of our platform. Next, what specific medical and clinical questions would you like the panelists to address? These are the questions. Is it possible to have guides that help in syndromic management of patients, given our limited clinical platform to perform tests, and also seeing we are resource limited setting where most patients don't have financial support? And thirdly, our facility is very far off from most amenities. Second, what do we do when the caregiver is not very supportive in the management of the patient? With adolescents and changes in behavior and influence from peers, how can we effectively support these young people to stay on treatment? Are there any learning or take-home messages? These are the following take-home messages which we can pull out. The managing complex cases as a team help us attain success. When caregivers are supportive, we can achieve better clinical and psychological outcomes with adolescents. Thank you very much. This is the case which we had in the Ngwa District Hospital. We are now open for suggestions and way forward in managing a challenging case. Thank you very much, Dr. Vanessa.
Kwasi, Dr. Jute. Thank you very much, Dr. Jute. And again, we are keeping it very real. Thank you that you could step in. Is located several kilometers away from town, and I know the network challenges that you can have. Thank you for presenting the case. Again, if you are joining us, we are talking about management of high viral loads for children and adolescents living with HIV. So I'm going to now invite our experts, Dr. Sandrine, Dr. Atanga, to give their contributions to this case. Thank you.
Thank you, Dr. Vanessa. Thank you, Dr. Ambe and the team in Moi. It's obvious that it's really challenging that way, even looking at the issue with network. And I can also understand how difficult it might be to manage these young people, these young Cameroonians in those kind of challenging platforms and situations. So thank you so much for what you're already doing. We have a number of questions. I will leave the first one about this, having the syndromic management for Dr. Atanga to handle that, please. So what do you do when the caregiver is not very supportive? So I think this just joined what the other cases where we are seeing just about the same kind of issues. But the first thing is to understand, like we said, why is the caregiver not very supportive? Understand the family dynamics. Why is it that the caregiver is not very supportive? In this case, the mother of this child, if I remember very well, this mother is also positive. And so she knows what it is to be on treatment, but why would she not be very supportive to her daughter? There might be some struggles that she's going through. There might be some things that she's going through that we are not very much aware of. Maybe it is who knows? It could be that it is in the relationship with the father of this child that she got infected, and so she's carrying and putting that in, transferring that aggression to the daughter, and so she doesn't want to have anything to do with her. So it is really very important to understand, why is this caregiver not very supportive? What are the fears that she has? And once we understand what are her fears, we can help them navigate through those fears, and then we accompany them through the process. The second thing is, we have already said it is important to identify who is the principal caregiver of this client, and then explore the option of getting some other persons who can really be involved in this child's management, if it's possible. I see here that, I don't know, it's like the grandmother with whom she's living, it's a Jehovah Witness. And we also know how religion impacts on some of these things sometimes. So if we could have somebody from the church to also, to be involved and support, maybe to talk to the grandmother or to talk to the mother, that could also help in a way to sort out issues that may be happening in the families and for which they don't have any response. So that particularly for this child, I'm afraid this child might even be having some mental issues, because why would she be abandoned in a house alone? Could it be that she has some suicidal thought? So we might also benefit in assessing her mental health to know what is happening. She's obviously might be suffering from rejection as well. And those are some of the things that looking into can help us to offer a little bit more of support to this child, even at the level where we are. How do we effectively support these young people to stay in treatment? I think one of the things is just to identify them early. And that's why we insist on identifying, going out looking for them. Those of them who are already positive, we look for them early and we put them on treatment early. And the other thing will be to make sure that we support them as they go through the process, making sure that they get their disclosure on time, making sure that we offer them the best services that we can offer to them within the means that we have. And of course, we have already talked about peer-to-peer support, which is really very important. Possibility to have support group, even if they are community support group. If we find ourselves in places where we have very, very small number of clients, we can organize community support group where we have people from the same age coming from this different facility, and they can come together and just share as pair and learn from each other. I think Dr. Atanga did mention having a parents also a relative support group that where they can also learn from the parents of those who are doing well. And finally, I will say that it is important to identify other support system where we can link these people to. Obviously, in some setting, it's really, really difficult, but if there are other support systems, like this child, she's not going to school, she's not doing anything, can she benefit from some in this kind of places? You could have some small kind of project where they are supporting maybe girls to learn a trade or something. Those are some of the things that we should have our ears on the ground to know if it's available in our setting, and just link our client to. I will stop here, and thank you so much giving the floor to others. Over.
Hello.
Yeah,
Thank you very much, Dr. Sandri. I'm
Doctor. Okay, Dr. Atanga, go ahead.
Yes, I
Dr.
know we
Alice.
are actually, time is not on our side. Yes, I just wanted to cue into, with what Dr. Sandrina said, I'll start by thanking the team for the presentation. I know it's quite challenging, and Dr. Ambe was asking in a situation with a very limited technical platform, what should they do? What should they prioritize? I think the first thing we need to know is, the case we presented, that's a very clear case of an advanced HIV disease, even the other cases that we have presented. And then when you find yourself in a situation like that, we've always said, please, we treat the patient and not HIV. Because if we focus so much on HIV, we risk losing the patient like that. If you were able to bring back this patient, it means you took that principle into account. It means that you see the patient globally, forgetting whether they are living with HIV. You had a patient who was completely emaciated. She was having diarrhea. She had skin infection. She had urinary tract, and even might be vaginal infections. So the most important thing is to identify and treat all these basic conditions even before thinking of getting the patient back on treatment. So at that moment, the ARV treatment is not priority. Priority is to the opportunistic infections that the child has, which are putting the child's life at risk. This child needed to be rehydrated. It might be needed to treat anemia and treat the basic infections. And so we need to do that. I think we have guidelines that we can use to treat syndromic management of patients. But in advanced HIV disease, in every situation, we need to screen for TB. This is an adult, screen for crypto, screen for toxo, and then make sure that we see whether their treatment is optimized, make sure that their follow-up is optimized, and all of that. So I think those are some of the things that you needed to do. Screen and treat all the OIs first, and then make sure that they are stable, and then you go back on their ARVs, and then also follow up to make sure that they're taking it well. I mean, the mental health here is something that is very, very real. You can't do without looking at the mental health condition of this child. The child is not under good condition. The child is abandoned and not going to school, and therefore, you needed to also screen for mental health conditions. I think the last thing that Dr. Sandrine said, which I still want to emphasize, is please, when you have an opportunity to manage children, don't look only at the resources you have at your level. Try to look, beyond the hospital into other services, other NGOs that can support these children, because this child needs support. This child should have been going to school or learning a trade, and just sitting at home is very, very bad. And I'm sure we have NGOs in the communities that could come in to help. So please reach out to such organizations to see how you can link some of your clients to them. And I think their role in just supporting those clients might be providing them education, providing a bit of nutritional support, and some psychological counseling will also help in the care of the child. And at times, the family might even come in when they discover that the child is being supported by others and the child is doing well, and the family that was even negligent might actually come in. So always think about that. Check around your around your facility. What are the other supporting structures that are there beyond, in social affairs, in women's empowerment, in the youth and animation centers, and all those other programs. I think the orphan care program is also there, which also supports some of these children. So use those, and you might be able to have a child stabilized, and then you'll be able to treat the HIV better. Again, she has a very high viral load. She's on TLD. It is very, very obvious that it's just an adherence problem, which if we resolve, we might be able to bring her back to suppression. Thank you, and over.
Okay, thank you, Dr. Sandrine, Dr. Atanga. In addition to what you have said, I just want to say that we have put in place the Recache Plus. Le Recache Plus is le réseau camerounais des adolescents et jeunes vivant avec le VIH. And then we have the representation within the 10 regions. I'm telling you, when you have this kind of child, as Dr. Atanga said, it's not more the issue of the health facility only. Because at a certain time you say, this could be my child, this could be my aunt child. my sister child also, you go, vous partez au-delà, c'est-à-dire de ce qui est prévu pour eux. On a le réseau camerounais des adolescents et jeunes vivant avec le VIH-Sida au Cameroun. Et pour ça, lorsque nous avons des cas comme ceux-ci, c'est-à-dire que, parce que lorsque vous suivez les histoires de ces enfants qui font partie de ces réseaux sur tout le territoire national, ce sont des enfants qui ont traversé beaucoup de difficultés. Mais aujourd'hui, lorsqu'ils se retrouvent, they talk about their condition of life, the lifestyle, and this. Mais je vous assure que c'est un traitement inédit. Vous allez voir la plupart de ces enfants aujourd'hui. Je voyais ma fille Laura qui a soutenu son master à lyrique hier. Parce que quand ils se retrouvent entre eux, c'est-à-dire qu'ils ont le langage au même niveau. Donc, je voudrais tout simplement dire que vous pouvez entrer en contact avec le président régional du RECAJ Plus pour la région du Nord-Ouest. Je ne sais pas si c'était le Sud-Ouest, j'avais des problèmes de réseau. Et essayez de voir comment vous pouvez mettre cet enfant en contact avec ce dernier. Je vous assure, faites-le et dans les prochaines réunions, vous allez nous donner quel a été le devenir de cet enfant. À côté de ça, je suis d'accord avec vous, lorsque la famille réunie, comment est-ce qu'on va dire, lorsqu'ils ne travaillent pas ensemble pour améliorer la prise en charge de cet enfant, ça devient difficile. Mais nous, à notre niveau, nous devons jouer un rôle. Au-delà des financements ou encore de ce que nous avons dans la formation sanitaire, il y a des assistants sociaux dans les formations sanitaires. Dans les formations sanitaires, nous savons qu'il y a des financements qui sont disponibles pour apporter de l'aide. Dans nos locaux, nous savons qu'il y a des élites. Bon, ici, on va parler du secret professionnel et tout ça. Mais il faut toujours discuter et voir vraiment comment on peut apporter nos aides à cet enfant. Ces enfants n'ont pas décidé de naître, je le dis toujours, ils n'ont pas décidé de naître. Et du moment où ils sont nés et ils sont infectés, nous devons tout faire pour apporter nos soutiens à ces enfants. Voilà ce que je voulais dire par rapport à tout ce que les autres ont dit. Merci.
Merci, Dr. Alice. I will try to get in contact with the Rikash. I think what you're bringing up is very important because we have the network that is very strong in town. But when it comes to some of these facilities that are very far off, we are not very sure what is happening there. So I'll try to have a session with the president of Rikash Blue in the Northwest and see what is possible, how they can link and support these adolescents who are in these very far off areas. So thank you very much, Dr. Ambe. I'm going to follow up on that and I'll give you a feedback so that we can see how to help this child. Okay. If you are just joining us again, we are talking about management of high viral load for children and adolescents living with HIV. And so we are going to just move into the second part. The first part was really to have some real life cases from the field. And so the second part is just for us to see some of the updates that have been done to the guideline and how do we confidently manage these children with high viral load. So I'm going to give the floor now to Dr. Alice, who is going to bring us her presentation. Please, as she's presenting, if you have questions, do well to put them in the chat. And after her presentation, we are going to also have Dr. Atanga speak to us about active management of high viral load. So Dr. Alice, thank you. Please, let's get our friends to join. Those who are still to join us, let them join us. If you need interpretation, please go to the more icon at the bottom of your screen. You click on it and you see interpretation and you click on that and you'll be able to get interpretation. Thank you, Dr. Alice, you have the floor.
OK. Merci, docteur, de me passer la parole et bienvenue une fois de plus à tous ceux qui ont pris la peine de se connecter malgré l'invitation autour de ce pataril qui a été faite avec un léger retard. Donc, il m'a été demandé, selon les nouvelles directives de prise en charge du VIH au Cameroun, de partager avec vous quel est le suivi de la charge virale chez la femme enceinte, la femme allaitante, les enfants et les adolescents. Donc, ça, c'est le plan que nous avons fait. Je vous ai déjà dit ici que c'est une présentation de 3 slides. Donc, nous allons parler du suivi de la charge virale chez les femmes enceintes et allaitantes. Nous allons parler du suivi de la charge virale chez les enfants et les adolescents vivant avec le VIH et nous allons conclure. Next. Donc, en introduction, nous savons tous que la prise en charge du VIH chez les femmes enceintes, allaitantes, et également les enfants, les adolescents, je voudrais dire dans toute la population générale, demeure une priorité capitale pour le gouvernement camerounais. Donc, ce qui justifie, oh là là, ça c'est pas ça. Donc, ce qui justifie la révision du guide de prise en charge qui a été fait l'année passée en 2024, il faut également soulever que avant la révision de 2024, notre dernier guide de prise en charge datait de 2019. Donc, pendant cette présentation, nous allons mettre l'accent sur les directives de suivi des examens de charge virale chez les femmes enceintes, chez les femmes allaitantes, les enfants et les adolescents vivant avec le VIH, tout en sachant que la charge virale, c'est un élément important pour le suivi de l'efficacité du traitement ARV, mais surtout pour la détection précoce des échecs thérapeutiques. On va commencer avec le suivi de la charge virale chez les femmes enceintes. D'après notre directive de 2024, comme vous pouvez le constater, donc, nous avons ici plusieurs catégories de femmes enceintes et de femmes allaitantes. Donc, pour la femme enceinte, on va commencer par la femme enceinte dont le statut VIH est déjà connu et donc elle est déjà sous traitement ARV. Nous allons également parler de ce suivi pour les femmes allaitantes, non, pour les femmes enceintes, autant pour moi, qui ont été dépistées pendant la grossesse et qui ont débuté la prise des ARV. Nous allons parler des femmes allaitantes VIH qui étaient déjà sous traitement ARV et nous allons parler des femmes allaitantes dont le statut a été connu pendant l'allaitement et qui ont débuté le traitement ARV. Nous commençons par les femmes qui sont déjà VIH positives et qui sont déjà sous traitement. Lorsqu'elles sont enceintes, vous, en tant que prestataire, qu'est-ce que vous devez faire? Excusez-moi. La chose que vous devez faire, c'est de rechercher déjà dans son dossier médical ou sous forme d'interrogatoire la charge virale la plus récente. Ça, c'est pour celle qui est déjà sous traitement ARV. Maintenant, si vous avez les résultats de la charge virale la plus récente, si vous constatez que cette charge virale est supérieure à 3 mois, qu'elle date de plus de 3 mois, on vous demande de refaire la charge virale au premier contact avec la femme enceinte VIH. Maintenant, si la charge virale est supérieure à 1000 copies, qu'est-ce que vous faites? Vous devez renforcer l'observance, puis vous refaites la charge virale après 3 mois. Si cette charge virale de contrôle est encore supérieure à 1000 copies, après 3 séances de renforcement de l'observance, en ce moment, il faudra déjà penser à switcher cette femme vers un traitement de deuxième ligne. Pour la femme qui a été dépistée pendant la grossesse et qui a été mise sur traitement, ce que nous conseillons ici, c'est de faire la charge virale tous les 3 mois. Maintenant, pour la femme allaitante qui était déjà sur traitement ARV, la chose à faire, c'est de rechercher la charge virale la plus récente. Et si vous constatez que cette charge virale date de plus de 3 mois, on va vous demander de refaire la charge virale. Mais si cette charge virale est supérieure à 1000 copies, on vous demande de renforcer de l'observance et de refaire cette charge virale après 3 mois. Pour la femme allaitante, dont le statut a été découvert pendant l'allaitement, ce qu'on vous demande de faire, c'est simplement de faire la charge virale après 3 mois. Qu'est-ce que j'ai dit? Pour la femme enceinte qui a été dépisté pendant la grossesse. Excusez-moi, parce que ce que j'ai dit tout à l'heure, il y a une erreur. Il faut faire la charge virale 3 mois après le début du traitement ARV, alors que la femme allaitante qui est dépistée pendant l'allaitement, on demande donc de faire la charge virale après 3 mois. Diapo. Pour ce qui est du suivi de la charge virale chez l'enfant et l'adolescent infecté au VIH, nous devons déjà savoir que la prescription de la charge virale doit être faite 2 fois par an jusqu'à 24 mois pour prévenir les résistances des ARV fréquentes chez l'enfant et l'adolescent. Donc, ça veut dire que ça doit être fait 2 fois par an pendant 2 ans successifs. Maintenant, si pendant qu'on fait l'examen de charge virale, si on se rend compte que ça ne marche pas, c'est-à-dire comme les cas qui viennent de nous être présentés, vous voyez qu'il y a des charges virales qui ont été faites de façon successive et le taux de virémie était toujours élevé, on demande de faire un contrôle de charge virale 3 mois plus tard, après avoir renforcé l'observance. Et il faut adapter la posologie des ARV. Maintenant, si la charge du viral de contrôle est non supprimée, on dit que le changement thérapeutique doit être réalisé. Ce sont des informations contenues dans le document de directive qui a été mis à la disposition de tous les acteurs intervenant dans le système, voilà, de prévention et de prise en charge du VIH chez les personnes au Cameroun. Diapo. Donc, en conclusion, on va simplement dire que le Cameroun, comme tous les autres pays, s'est aligné aux objectifs 95-95 d'ici 2030, c'est dans 2 ans. Donc, l'atteinte de cet objectif passe également par le suivi de la charge virale chez la population générale, mais en particulier également chez la femme enceinte, chez la femme allaitante, les enfants et les adolescents vivant avec le VIH. Il est donc urgent que ces directives revues au Cameroun en 2024 soient soient respectées par les prestataires de soins dans l'ensemble de nos formations sanitaires. Il est également important que ceux qui sont au niveau de la coordination fassent une prestataire parce que nous savons le phénomène a formé de mentoring dans nos formations sanitaires pour accompagner ces prestataires à ces nouvelles directives qui ont été validées par le gouvernement camerounais et qui ont été mises à disposition. Donc, nous restons disponibles pour d'éventuelles questions par rapport à ça. Et docteur Bit, ce que nous allons faire également, nous allons mettre à votre disposition ce guide de prévention et de prise en charge du VIH au Cameroun qui a été validé. Je vous remercie.
Merci beaucoup, Dr. Alice, pour les présentations. Thank you again very much. I see Leslie has their hand raised. Setase Leslie, you have the floor. Please, if we have comments, questions, contributions, let's put them in the chat and use the chat as well to introduce yourselves. Thank you.
Thank you for giving me the floor, Dr. Vanessa. Thank you, Dr. Alice, for your presentation. Docteur, j'ai un souci. D'après votre présentation, apparemment, on ne fait plus de tests de résistance pour passer de la première à la deuxième ligne chez les femmes enceintes. Donc, ça veut dire ici, après le conseil à l'observance, et 3 mois plus tard, on se rend compte que la charge virale est toujours élevée. Le prestataire devrait donc passer à la deuxième ligne. Est-ce qu'il n'y a pas un risque qu'on sature les femmes à la deuxième ligne? On ne devrait pas être à la deuxième ligne. C'est la préoccupation qui m'incombe ce jour. Merci.
Merci, votre question a été notée. Est-ce qu'il y a d'autres questions? OK, en attendant d'autres questions, je voudrais simplement dire que c'est une très bonne question que vous avez, que vous avez posée. Je vous ai déjà dit que cette question a fait l'objet de plusieurs disputes, de plusieurs échanges pendant les ateliers de finalisation et de validation de cette directive. Cependant, je voulais quand même m'attarder sur un élément qui est important, n'est-ce pas? Il faut investiguer parce que si vous avez une femme enceinte, chez qui la charge virale est restée non supprimée et vous refaites la charge virale et non supprimée. Si vous n'investiguez pas, parce que si vous avez une femme qui fait l'examen de charge virale, elle ne supprime pas, et lorsque vous lui posez la question, plus tard, elle vous dit que non, parce qu'elle est fatiguée de prendre ses médicaments. C'est-à-dire que vous savez, elle vous a dit qu'elle ne prend pas le médicament, elle n'est pas observant, elle n'est pas... Est-ce que vous allez mettre cette femme, est-ce que vous allez mettre directement cette femme en deuxième ligne, sachant que cette femme n'est pas observante à son traitement? Donc, ça, c'est ce que disent les guides. Mais si vous avez une femme qui vous dit carrément que non, la charge virale a augmenté parce que j'étais en déplacement et mon remède est resté, je dis n'importe où, je pense qu'il est important, à mon avis, de voir comment est-ce que vous pouvez encore, bref, renforcer peut-être les capacités de renforcer l'observance thérapeutique chez cette dernière. Donc, du moment où on vous demande de changer, c'est lorsque vous vous rassurez que, c'est-à-dire que vous avez évalué l'observance chez cette femme, ça n'a pas marché. Elle prend les médicaments, mais sa charge virale ne baisse pas. Quand vous lui demandez qu'elle revient au prochain rendez-vous, vous vous rendez compte que non, après évaluation, c'est-à-dire vous vous rassurez qu'elle prenne les... Maintenant, la rassurance, c'est en utilisant la méthode indirecte. C'est simplement pour éviter, parce qu'on a une femme enceinte, le risque de transmettre la maladie, le virus à son bébé. Je ne sais pas si vous avez un peu compris ce que j'ai dit. C'est-à-dire que c'est le cas par cas. C'est vraiment le cas par cas. Et parce qu'on a une femme enceinte et on a peur qu'elle transmette le virus à son bébé, parfois, il faut déjà penser au passage. Maintenant, sachez qu'une femme qui n'est pas observante, c'est-à-dire que si vous passez à la deuxième ligne et qu'à la deuxième ligne, elle ne prend pas toujours son médicament, on est d'accord? Vous serez obligé de faire quoi? De passer à la troisième ligne. C'est pour ça que vous, en tant que prestataire, au-delà de ce que disent nos directives, vous devez prendre ces femmes de façon individuelle. Je ne sais pas si j'ai répondu à votre question, mais comme je vous dis, la question que vous posez aujourd'hui a fait l'objet de plusieurs questions lors de l'élaboration de ces documents. Merci.
Merci beaucoup, Dr. Alice. Please, for the sake of time, let's use the chat box to ask our questions. I'm going to hand the floor to Dr. Atanga now to make his presentation. At the end of his presentation, you can still ask questions related to this first presentation, but I think his presentation is going to answer some of the questions we have. So let's listen to Dr. Atanga speak to us. Thank you again, Dr. Alice, and please just be on standby for questions. Thank you. Dr. Atanga, you have the floor.
Yeah, thank you very much, Dr. Vanessa. And once more, good afternoon, everyone. So we're going to be talking about identification and management of children with high viral load. Just for as an introduction, some terms. When we talk about the viral load, we are actually making reference to the quantity of the HIV virus found in the blood. And this is usually measured by looking at the number of viral RNA that are there in the blood. So we should not make the mistake, not a diagnostic test, it's actually a test for follow-up. We usually will measure the viral.
Hello, Dr. Atanga, can you hear us? Hello, Dr. Tanga. Please, let's just give it a moment. Again, we are in a reel and we know our situation with network. So let's just give him a moment. I'm hoping that he can get a more stable network. Hello, Doc.
Yes, I'm sorry. I don't know what happened. It suddenly broke from my end. Can you get me now?
Yes, we can hear you now, Doc. Thank you.
Okay. Let's just move to the next slide. So when we talk about viral...
Angelita, please move the slide.
Slide, please.
Yes, the slide is on viral suppression now.
Is the slide moving? I don't see it moving from my end
Yes,
yet.
We are on viral suppression.
Okay. So we just
yes, Doc.
Had a definition of viral. Yes, we just had a definition is viral. Are you getting? Dr. Vanessa, are you getting me?
Yes, I can hear you, Doc. Please go ahead.
Okay, so I was just saying that when we talk about viral load, we are interested in viral suppression, and by viral suppression is defined as 1,000 copies, less than 1,000 copies by WHO. And I think this definition has been used since 2016. And when we also talk about undetectable viral load, we are also talking about a viral load that is less than 50 copies. We have some machines that measure less than 40 copies, but the standard is 50. So once the viral load is less than 50 copies, it becomes indetectable. So when it's undetectable, it means you don't find the virus is so small in the blood that even the machine can't read any viral viral particle. But that doesn't mean that the virus is absent. So we also have the U equal U notion, which we all know is actually describing on undetectable viral load, which equal to untransmissible. I think there are quite a lot of studies that have shown that when your viral load is very low, that is when you are below 50 copies, the risk of sexual transmission is almost absent. So at less than 50 copies, we don't have mother-to-child transmission is almost zero, and sexual transmission is almost zero. I think there are quite a good number of studies that have even shown that sexual transmission is almost impossible below viral loads less than 200. Slide. So when we talk about high viral load, generally we say when the viral load is above 1,000 copies, we refer to it as a high viral load. And when your viral load is high, then there is a risk of treatment failure. But you only define treatment failure when you have a viral load of more than 1,000 over 2 consecutive measurements taken at least 3 months apart with good adherence in between. So these 3 conditions need to be met. The viral load should be above 1,000. They should be measured on 2 consecutive visits, and then with at least 3 months in between. And during that period, the patient should not have any adherence problem. Once that is met, then the patient is actually defined as having a treatment failure. So treatment failure is only when you have those 3 conditions met. I think the slide, just click again. The scenarios here is just to show us. No, continue, Doctor. Yeah, the scenarios here is just to show us the different readings. we said that the viral load can be above 1,000. That means that you are not suppressed. But when you have a viral load below 1,000 copies, then you are suppressed and you should maintain your treatment. And when you have an undetectable viral load, you are actually undetectable and you should maintain your treatment. But when you are with a viral load above 1,000, then you need to question the risk of treatment failure and the possibility of switching the patient if they are actually in treatment failure. Slide. So this slide just showing some studies that are done in Cameroon to actually show that viral suppression for children and adolescents is quite challenging compared to adults. And these studies were done by the Focam and team at the Chantabia International Reference Center. They were done at two times. You see here that when the study was done before 2017, the viral suppression for adolescents was poorer than for children. But when they repeated the same study in 2022, the viral suppression was much better amongst adolescents than children. So again, as we are moving, the dynamics seems to be changing. A lot of attention has been paid to. We had more. The children were better off, and then later were better off. But generally, children and adolescents have a more challenging part getting their viral slide. Yeah, so when we talk about management of children with high viral load, I think we know we have here, we are talking about children and adolescents here. Generally, most of the adolescents or some of the adolescents that we'll be dealing with will actually sexually active. And one of the first things you need to do if the adolescent is already sexually active is also to do contact tracing for all their sexual partners. So that you should not forget. Like the cases we saw this afternoon, some were already sexually active. And so if their viral load is high, the risk of transmission is very, very high. And so identifying and treating their sexual partners is very, very important. But for the children, I think that's not the case. And you just manage the high viral load as required. Slide. That's a national algorithm for for viral load. We all know we either get the viral load prescription as part of the routine monitoring, or we get a viral load prescription as a target. As a targeted in case we suspect clinical or immunological failure. So for the routine, I think that is what Dr. Alice already exposed when she showed us the national guidelines, what needs to be done for children and adolescents. So once the viral load is done, you either have a viral load that is
Sorry, let's just be patient. Dr. Tanga, we lost you again, if you can hear us.
Elucidate this clearly. What are we measuring, 3 months or the 6 months? Yeah, so if you repeat the test and it's less than 1,000, then you are good to go. You maintain the first line treatment. But if it's more than 1,000, then you might have to, you should move your patient to a second line treatment. Because if you delay on the first line treatment, then you just accumulate more resistance and then treatment becomes even more difficult. Slide. So I'm sure every facility, most of the facilities that are presented today, you should have this very important document, the high viral load register, and it is a very important tool because it is a longitudinal register that is actually meant to monitor a child or a patient with a high viral load. So once the patient is diagnosed with high viral load, they're entered here, and then the plan of their follow-up is also aligned You see the 3 adherence sessions, the repeat viral load, the results of the repeat viral load. If it is suppressed, we continue. If it is not suppressed and adherence is not yet good, we have to repeat. We go again for additional sessions. So the high viral load register is very, very key. I'm sure all of you are using this slide. So that's the first part of the register, and this first part actually handles the enrollment of the client up to the first repeat viral load. And if the repeat viral load is good, then you maintain the treatment and then the patient stay. But if it is still high, then and your last evaluation is either fair or poor, then you have to continue 3 additional sessions until you get a good adherence, and then you repeat. And if after that repeat you don't get you get a high viral load again, then you have to switch slide. So that's the second half, which is the additional sessions in case your first session ended with a poor or fair adherence and the viral load was still not suppressed. You don't go ahead to change the child's treatment. You rather go for additional sessions by trying to identify the key reasons for the treatment failure, and then you go for additional sessions, and then you repeat the viral load slide. So this is just to show you, because I was saying the 3 to 6 months at times is usually a bit to interpret. And this is what I want to get you understand here. When you receive a viral load result, and some days here just to show, when you receive a viral load result, the client, you are expected to call back that client to the facility to receive their result. And if they come back to the facility to receive their result, that is that is when you start your first adherence session. So if you see here, this client, for example, received the results came on the 5th. They called the client on the 12th. They called the client. The client effectively came to the facility on the 16th. So that was 4 days after. So the patient is now in the facility. So that is month 0 because it's not yet month 1. So this is the first. This is the patient coming back to receive those results. And once the patient receives the result now, at this first session, you are going to enroll them into EAC by identifying all the adherence challenges that they have. You are going to adopt a plan of action with that client, and then you do contact tracing if it's an adolescent, as we said, and then you reschedule. You refill their drugs and you reschedule them. So by the time the patient comes back in month 1, that will now be so from the 16th to the 16th, that's the first month. So the patient now has been in a EAC for 1 full month. So you receive the patient on that second EAC. The same thing you do is you start by re-evaluating the extent of implementation of the plan that was agreed on in the first session. And once that you evaluate that, you see what progress the patient has made, and you see where they still have challenges, and then you reinforce where they still have challenges, and that culminates now into the new action plan that you are doing with the client. Then you refill their drugs, and then they go again. Once that is done, the client goes back, and then the client the next visit will be in March. So the client was now, that's the second month that has gone to completely. So when the patient comes back now, that's the third adherence session. So you now reevaluate the client at that time. And once you reevaluate that client, and the client is adherent, you reevaluate adherence as usual. And once that is done, you now evaluate if there's any other challenge. If there is no challenge, then you have had 3 consecutive months where the patient has actually had EAC, and they have had their distance. So what you are expected to do is to now schedule the recollection visit appointment, and that should be done one month after that. So the client would have had 3 full months of adherence counseling, and then now the client is getting their repeat their viral load at the 4th month. Slide. So if you were to find yourself in a situation where you needed to do an extended session, this is now a combined listing. You see here, the client came we had the ESC session in month 0, and then month 1, month 2, and then we plan recollection at the 4th month, at the 4th session, and then in that recollection at the 4th session, now you see that the client was not, if the client did not do well, instead of doing the recollection, you go straight to the first extended session. So the first extended session will start at the 4th month. Clients that were not suppressed at the 4th session, for clients that were not suppressed at the 3rd session, but then it will be a recollection for those who were actually suppressed at the 3rd session. So that's the first thing that you need to note. And if that is the case, when you now have a patient who has crossed the 3 complete sessions, you now have, that's where you see 6 months come in there, because successful, might be one was successful, one was not very successful, and you decide to go for extended sessions. You don't have to go for for 3 complete extended sessions, because if the adherence was good at session 1, at 2 and 3, you needed to recollect. If it was good at one and not good at the other, you need to extend. So if at the 4th session, after evaluating the client, the adherence is good, then you will do your recollection. So you are not going to complete all the 3 additional sessions. If here you still had adherence challenges, then you do a plan for the 5th session, and if that 5th session comes out with a satisfactory adherence, you can collect, or else you now do a third listing, a 3rd plan, and then you only plan recollection after 6 months. So when you look at this, you see that you have up to 6 months to actually recollect the client. So we need to do as strategies possible to make sure that we can recollect the patient between 3 and 6 months. So from the 4th to the 6th month. Slide. Yeah, so for each client that comes with a high viral load, you use the high viral load form, which I'm sure our facilities do have, please. If you don't have this, then it might be very challenging for you to follow up clients with high viral load. If you look at this form very carefully, you see that the upper section here, which is actually the opportunity to also do what we see staging. I'm sure this is not very, most people might not be very familiar with this. When you diagnose a patient with HIV for the first time, you do a WHO classification, which we know what to do, looking at whether it's the patient is stage 1, stage 2, stage 3, or stage 4. That classification should not change throughout the patient's treatment. But what happens is that in reviewing patients in the course of treatment, you do a very similar exercise. So when you do that classification during treatment, you don't just call it the WHO classification, because it might confuse that classification with the classification that you had done at the beginning. And it's always very good that we know at what stage the patient started treatment, because these are patients that are chronic care patients, and 20 years after, we should still be able to know that that patient started at stage 3 or 4. So when you now do a classification, when the patient is already on treatment, that is what is referred to as the treatment classification. That's why it's called the WHO T staging. So you make sure that at this point you have a staging 2 for that patient, but that staging now is a staging with the patient on treatment. So once that is done, you then do the other evaluations, and you actually evaluate the patient's adherence, and you see it here. That's what is called here in the green, in green, either as good, fair, or poor. And you also do your normal P count, which you would do, but do it in a way that is not judgmental, and in a way that the patient doesn't feel like you are actually taking them. I mean, you don't trust them. Slide. So after you fill that section, the second section of the form gives you the opportunity now to do an evaluation of the possible barriers to this thing, to treatment, to ARV or to adherence. And those barriers are actually listed here. I think this list is very, very exhaustive. It might not include everything, but it's very, very exhaustive. And then you make sure that you find out what are their challenges that they're having. And then you use these challenges now to come up with a plan. Slide. So on this other third column now, slide, you now have the possible interventions that you can put together with the client to be able to follow during their refills. So you evaluated the adherence, you identify the barriers, and then after identifying the barriers, you now came up with an action plan. And in that action plan, you will see the different interventions that you can do following the different action, following the different barriers that we identified. And then that is what you agree upon with the client, and that is what they are going to do in the next 1 month to see that their adherence improves. Slide. So in subsequent visits, you are simply going through this same process. Whereas in those subsequent visits now, you have the session 2, you have the session 3. In session 2, what you are going to do is you're going to reevaluate the plan that was made in session 1. You see what the patient has been able to achieve. You see where they still have challenges, and then you identify those challenges together with them, and then you jointly develop a new plan that is going to be which is going to implement, or he or she is going to implement during that the second month. And when they come back for the third visit, you are going to do the same, and then you re-evaluate and you see what they need to do in the course of the third month. And then by the time they come back for the evaluation, you are now preparing them for a recollection. So you are either concluding whether they are ready for recollection or not at the end of the third session. Slide. Slide, Dr. Vanessa. So you now have this in case you don't successfully you don't successfully recollect them because of the poor, or because adherence was not yet good. Then you will now have to move to additional sessions. And as I said, additional sessions come in progressively. If you take an additional session and you do perfectly well with the additional session, you don't need to go for extra sessions. You can actually plan the recollection after that successful additional session. But if not, then you have to go for another.
Hello,
Yeah. Yes. Are you getting me now?
Yes, Doc.
I was
hear you.
actually saying that when we at every visit, we reevaluate the plan of the previous visit, see how far the patient has gone in terms of improvement, identify the challenges that are still left, and then use that to prepare the plan for the next session. So when we do now, and we get to the third session, and if the client is still not really adhering well, then you will not plan the recollection. You will rather move to the fourth session. And this on this slide now, you see here, you have the additional sessions. And that's what I was saying, that the additional sessions, you don't need to complete 3 additional sessions before recollecting the client. By the time you are at the fourth session, you just evaluate and make a plan of action. And once the patients come back and successfully implemented their plan and the adherence is good, you can plan their recollection in the next session. So that's how it goes. And then you you have the results. And if they are not at the end of the third additional session, if your patient is not adhering, then you have to move them to the next line of treatment, because this procedure will happen whether you're moving from first to second line or from second to third line. So once you do that and you don't have this thing, you might have to. So if you were dealing with the first line, then you move them to a second line treatment. If you were dealing with the second line, then you have to move them to. If you have to move them to, you might have to do a resistant test, and then the resistant test will determine the third line treatment that you're going to do for the patient. Slide. So I think that is just the last slide, just showing us the viral load node suppression cascade. You have a certain number of patients who come in with a high viral load, and then you see those that go through a adherence counseling successfully, that enhance adherence successfully. Those that you recollect the first viral load, and then those that get suppressed, and then those that don't get suppressed, you move them to this thing, to treatment if the adherence was good. If adherence was not good, then you have to take them through another round of these things again, of sessions again, before you eventually take them out to the next line of treatment if they finally don't resuppress. So I think that's what I had to share with the team this afternoon. I know the network was not the best. I hope you were able to follow me. Thank you, and over.
Thank you very much, Dr. Tanga, for taking us through the presentation. And again, it is matter real, so it is expected sometimes. Thank you very much. Do we have questions? We've had a power-packed session starting from the real scenario of where to say that we can actually have, or we do have these children in our treatment currently. There's somebody, Magdalene. Please, I'm the one putting you on mute. So please don't unmute your mic again, please. There's Magdalene, please, somebody, a bender. Please don't unmute your mic. I'm the one muting you. Thank you. Okay, so I was saying that we started off with cases to show that we actually do have these children. And then we moved on to identifying and knowing who to do viral loads for, whether they be pregnant and breastfeeding women or children and adolescents. And then we've rounded off with how do we concretely manage these children with high viral load, which I know is a struggle. And Doc, just to respond to you, for some of the sites we are supporting, they actually do not have the high viral load registers. So we are trying to source for, as well as the forms for EAC. I have just shared the forms. We're hoping to share after this session because we wanted them to have some kind of training before they can actually go into using the form. So when we'll be going back to these sites now for mentorship, it will be around looking at how they are concretely using these forms. But we are still trying to source for the high viral load registers. Please, do we have questions, concerns, contributions? We are actually rounding off with our session. Any questions? I don't see hands raised. Is it that we've understood everything or we understood nothing? I'm just kidding. Please, do you have questions? Magdalene, your mic has been open. Do you have something to say? Magdalene and Benda. Sorry about that.
You mute her, she keeps unmuting and nothing.
Yeah. So please, do we have any questions? Okay, I don't see any hands raised. So I would just want to ask a question since we are not asking questions. Is the Baham team still online? Baham.
Yes, we are online.
Yes, thank you. So from Dr. Tanga's presentation, do you think that we would have avoided having this serial number of high viral loads for this child if we used the ESC form? And if yes, just tell us a bit how you're going to proceed now that we've had this knowledge about the ESC forms. Thank you. Doc, did you hear me? Yes, you can type if that's okay. Yes, you can type. I can read what you type. Same question goes to, I don't know, Dr. Ambe, are you still there? Dr. Ambe? Sorry for putting you on the spot. Yeah, because we need to use this to reshape what we're doing. When we look at the cases that were presented, you find that these children had series of high viral loads, but we are not very sure what happened before the next sample was collected, and then the next sample and the next sample, and the children were just on the same regimens, or even when the regimens were changed, it was due to optimization because of their weights. So that's why I'm throwing this back to us so that we relate what we are learning to our practice. It should not just end at, oh, we came, we had a session. When we go back concretely, how do we integrate this? Leslie, I'm going to put you on the spot. I know that you're going to speak for the district. So Leslie, can you just let us know how this is going to help change that management in your district? Thank you. People don't like being put on the spot. I'm sorry. Leslie, can you hear me? Am I still being heard, please?
Yes, we
Can anyone hear?
yes, we
Yes,
can.
Doctor, I hear you.
Okay, thank you. Leslie, can you hear me? I think not. Okay, Mr. Matthew, can you hear me? Mr. Matthew, all the way from Akko Catholic Hospital. Pascaline, please close your video. Thank you. Mr. Matthew, can you hear me? Apparently, all the people I'm calling don't want to speak. Please, we have to be open. Let's not be shy, because when we are shy, we are not going to get anywhere. So is there anybody who wants to speak as to what they are going to do? Because really, we don't want this to remain in theory. We want it to be translated into practice, especially with the new guidelines and everything that's coming up. Please, let's be snappy. We are actually rounding off with the call. There's a lot of me Vanessas on this call. I mean, we are just being real. I'm just amazed at how I multiplied myself. Okay, nobody really wants to speak. Oh, that's so sad.
Hello, Dr. Vanessa.
Yes, thank you, Dr. Ambe. Thank you. You have the floor. So
Sorry,
I was
it's just
asking that, do you
yes.
think, yes, let me ask the question again. So I was asking that, do you think with this ESC form and going through the high viral load register, we are going to do better? Because when we look at the series of viral loads that have been done for, especially like the child in ACO, and we have persistent high viral loads, it helps us to question, where did we do ESC between these sessions, and why did we keep repeating and having the same high viral load? So the question I'm asking is, do you think using the ESC forms or the high viral load register and the high viral register, not all, can help us to minimize or to tell us how we repeat viral loads for the children with high viral load, and what are you going to do at your site in our district hospital? Thank you.
Well, yes, I think with this is going to help us, protocols. Once we are versed with protocols and we follow them, it gives us guidelines on how to manage such cases, and then we know which steps to take and at what point in time. I think it was necessary, and even this presentation today was necessary because we had cases and we were kind of stuck on how to go about it. So I think it's very necessary that we do all of that. And with some recommendations, when you are doing something and you're all by yourself, you don't know where to go to or who to contact, you become stuck at one point in time. So the presentations today from all the doctors have seen a lot of things that we can really do to improve on our clients' situation, like the counseling, their peer groups, and so on. Talking about that and then following up all those registers, making sure that we follow the protocols. I think is going to be of great help to us. It's going to be of great help to us. So I think that is that. I really want to thank all the doctors for their quite lengthy presentations on all those when to collect the viral loads, how to follow up the pregnant women, and so on. this is just going to be like a refresher. Those will be times we have these manuals, these guidelines, but we neglect them. But with such opportunities like this, give us the time to go back again and review all those guidelines and then know on how much we can work. And then good enough, if we can get all those situations you talk about recap tools or something like that, you can get those contacts and other services contact that we can use to follow up these patients and also solicit for support and guidance from all these other NGOs. It is going to be of great help to us so that we can help to manage these patients and give them a comfortable life so that they can also be beneficial to the society. So that's just what I think I can say based on that. Thank you
Thank you
very
very much,
much.
Dr. Amde. Thank you so much for that feedback. And I think we are going to have another Pataril session in June, and it's still going to be Cameroon focused. Right now, I'm going to give the floor to our experts to just give us one last word as we round off with the session. So I'm going to begin with Dr. Sandrine. Dr. Sandrine, you have the floor, after which we'll have Dr. Alice and then Dr. Atanga. Thank you.
Thank you, Dr. Vanessa, for this opportunity. I'm sure that we have all learned one thing or the other with this month's Pataril section. I just want to encourage us to really put it into practice. Let's practice it so that when we come next time, we'll have story to tell. Thank you, and over.
Thank you, Dr. Alice.
Yes, doctor, thank you very much for involve us to this meeting. So I'm very happy knowing that we share the new guideline with those who were here. But there is the question on, there is a woman who asks whether we should wait 3 months before putting the... C'est comme si je n'avais pas bien compris la question là. Je voudrais tout simplement dire que normalement, les directives demandent, c'est-à-dire que même si vous avez une femme enceinte qui a été dépistée à 35 semaines, je dis n'importe quoi, si cette femme n'a pas encore pris les arrêts pendant 3 mois, ça ne sert à rien de lui faire l'examen de charge virale parce qu'elle n'aurait pas encore pris ses médicaments. Donc, je n'ai pas bien compris sa question dans le groupe et j'ai voulu corriger ça. Donc, il est important. Là, on dit que les derniers charges virales doivent se faire entre 32 et 36 semaines, mais il est toujours important de laisser la femme prendre les antirétroviraux pendant 3 mois avant de commencer l'examen de charge virale. Merci, docteur Atanga, merci, docteur Sandrine, et merci, madame Di, pour cette confiance à nous. Donc, ce sera toujours un plaisir pour nous de faire partie de vos panélistes. Merci à tous les prestataires qui ont été avec nous, tous les cas qui ont été présentés. Et je voudrais vraiment que les recommandations et les orientations qui ont été données séance tenante, que celles-ci puissent être prises en compte, sachant que ces enfants auraient pu être les nôtres, ces enfants auraient pu être les vôtres. Donc, au-delà de ce que nous avons dans les formations sanitaires pour appuyer ces enfants, on peut également chercher d'autres sources de support ailleurs. Merci beaucoup.
Merci beaucoup, Dr. Alice. Dr. Atanga, you have the floor.
Yeah, thank you, Dr. Vanessa, for the great coordination. I want to also thank all the presenters of today. The cases were great. I think they showed all the challenges that we have in our context. But I just wanted to highlight one key thing to say that with children, viral load suppression is not an easy task to reach. Children and adolescents, they have, I mean, it's much difficult with them, and so it needs a lot of clear follow-up. Secondly, I also want to let the clinicians remember that children don't suppress viral loads at the same rate as adults. So it takes a bit longer for children to suppress their viral loads because usually they start with much higher viral loads than most adults. And so they don't suppress too early. And so those are some of the things that you need to note. And then also to indicate that when it comes to the follow-up of these children, the guidelines are very, very key because if you don't follow the normal guidelines, and then you just have to you leave the children too long on a failing regimen, they tend to develop too many more mutations, and then it makes their subsequent treatments much difficult. So when we follow the guidelines properly and we get to the point where we think we have to change, because we've done all what it takes and we are at the point where we have to change, then you have to switch. Because if you don't do that, then you just leave the child much longer on a failing regimen, and then they accumulate more mutations, and that makes resistance even much higher, and the response to future treatment might not be the best. So I think that let's try to follow the guidelines. I was happy to hear Dr. Vanessa promising to make sure that all the sites have the tools, because again, without the tools, you cannot really properly evaluate what you're doing. But once you get the tools and you use them properly, I'm sure that you will see some improvement. Again, coming back to what Dr. Ketaji just said, please don't forget, don't take the management of children to yourself and completely. Remember that there are so many other structures out there which can provide a lot other services that will go along the line with to improve the child's care and treatment. So don't forget the social services that exist around you. Don't forget the NGOs that are there. They play a very, very
Thank you very much, Dr. Tanga. Once again,
most of them, they are even looking for opportunities to help some of these children. And when we don't reach out to them, they might not even know that we have children who are in difficulty. So please always check that net. Just check the network that is around you and try to use them.
hello, Dr. Tanga. Okay, I think the bottom line, we've gotten the message. I see Baham saying that this would be a good experience for them, especially with the EAC. So please, we look forward to you using it. Thank you, Madam Florence from the community. Of course, we cannot neglect the place of the community when we manage children with high viral loads. They come from community, they go back to community. And all our speakers have emphasized that let us always look out for structures around us and link our children to. Thanks to all the case presenters. Thank you, Angelita. Thank you to our translators for being in the background and making sure we have a seamless session. I also want to immensely thank the other participants and to say that we are going to have another Pata-Reel specific to Cameroonian context in June. So do feel free to reach out to me with topics you would like to hear in the next Pata-Reel. With that said, thank you very much for being there, and bye to everyone.
Bye-bye, Doctor. Bye to everyone.
Bye.